Good afternoon, everyone, and welcome to today's session. Today's session is about antibiogram basics and practical application. My name is Sahar Mohammed Hisham. I'm board certified infectious disease clinical pharmacist licensed here in the UAE as an infectious disease pharmacist and hold my master degree in clinical pharmacy. Today, our lectures is very important. Most common questions came to me regarding the antibiogram, so I decided to deliver a series about the antibiogram basics and practical application. In this session, we will cover for the basics of the antibiogram, what is it, how to interpret the antibiogram, and why it is such a powerful tool in guiding empirical therapy and building hospital policies. I have designed this series to start with the fundamentals, and then in the upcoming session, inshallah, we will move towards practical application on specific infections such as pneumonia, urinary tract infection, bloodstream infection, and more. For this so I will try to be focused, simple, and practical in our session. So before we dive deeper, let me know that we can have structured this teaching series so that we can know exactly what is expected. We will start with a couple of free sessions. First, today's lecture will be about the basics for the antibiogram, building the foundation. Then I will try to give you a practical application on the two most common specimen types, such as sputum and urine culture. So I will deliver for sputum antibiogram and urine antibiogram, and these are chosen because they are among the most common and relevant in the daily clinical practice. After that, for those who want to go further and to know more about the different cultures and different details about the antibiogram, there will be a paid advanced course. We will focus on this, on the detailed antibiogram interpretation in the major specimen type like respiratory, urinary, bloodstream infection, intra-abdominal infection, central nervous system, and catheter related infection, surgical site and wound infection, and other challenging cultures like drains, vaginal swabs, and CSF. Also, we'll do a hand-on case-based discussion to actually work together scenarios to know how to engage those antibiogram in their clinical decision. Also, finally, we will cover how to use this antibiogram in the policy building. So before we move to the main content, I'm trying to explore with you the intended learning objectives. And by the end of this lecture, you should be able to define the antibiogram, describe the purpose of the antibiogram in the antimicrobial stewardship program, recognize the most common used guidelines in the interpreting and creating antibiogram, which is the CLSI M39 guidelines. Explain how the antibiogram are used to guide empiric therapy in both community-acquired and hospital-acquired infection. And by the way, this is one of the most common question that came to me. So I'm trying to illustrate how we can use the antibiogram in both community-acquired and hospital-acquired infection. Also, we want to differentiate the role of the antibiogram in sepsis versus non-septic patient and apply this in the empirical antibiotic choice. As you will see that you will use the same antibiogram and you will deliver a different recommendation regarding septic and non-septic patient. Finally, you will interpret the antibiogram data in a pathogen-specific and syndrome-specific manner while avoiding irrelevant organism, and we will see how we can do this. Also, you'll identify the major limitation and potential pitfall for the antibiogram, how you can overcome the duplicate bias, the aggregate data, and the lack of the MIC, and the overestimation for the resistance. And how these major limitations can have a challenges for us in interpreting or using antibiograms. Also, we'll apply the local antibiogram data in combination with the clinical judgment and guidelines to make a rational empirical therapy decisions. So before we start, we need to know what is an antibiogram. An antibiogram, it is a summary for local antimicrobial susceptibility pattern. Okay, so the antibiogram is usually give us a report, a usual report in a simple term how effective different antibiotics are active against bacteria, which is commonly isolated in your hospital or in the community. It is usually prepared by the microbiology lab and updated once per year, and usually it's updated annually, not every 6 months, as I usually see in the many hospitals that they usually update it every 6 months, which is not appropriate. It's usually updated annually, and it reflects most recent local resistance data. What it displayed percentage of isolate, as I will see in the next slide, inshallah, how we can see the percentage of the isolate that are susceptible for each antibiotic. For example, it will show how susceptibility for example nitrofurantoin for E. coli in the urine samples. Okay, and most importantly, the antibiogram is a population tool, and it's very important to know that it's a population tool, not a patient-specific data. So it will give an overview about the population in a certain period, which is 1 year, and it will not be display the patient-specific data. So if you have the two choices, if you will decide which empirical therapy you will give it to the patient, you have both the antibiogram and also you have a patient-specific data. It's very important to know that it's highly recommended to rely on the patient-specific data rather than using the population tool or the antibiogram. So the next slide, it will be an example for the antibiogram. As you see, it's a report. Okay, this is the layout of the antibiogram. As you see, this is a table. Okay, it contains many columns and many rows. The first column, it shows the most common microorganism, and then the next column show the number of the isolates that are being appear during the year. Okay, and then the next columns for the different antimicrobials. For each row, it shows the different susceptibility pattern or the percentage susceptibility for each antibiotic for different microorganisms. For example, if we take an E. coli, it appeared 250 times in that year, and also the susceptibility for AMP, it's usually the ampicillin, it's usually 35%. So the ampicillin was sensitive to the E. coli in 35% of the cases. Okay, so we will interpret in the next slides what's the meaning for these percentage, but at this slide I only want from you to know that 35% it's the number of times the ampicillin was sensitive over 250 multiplied by 100 in order to get the percentage. So now we will talk about the antibiogram. It's important to understand that there is an international standard that guides you how you can prepare the antibiogram. The most commonly and widely used guidelines is called CLSI M39 guidelines, and it is used to provide us with the standards regarding the analysis, presentation, and how to create the cumulative antibiogram. Okay, so the key recommendations for these guidelines um, or that usually, okay, first, it's to ensure the reliability, you should use only the isolates that appear at least 30 times per species. So if you have like Proteus or Shigella or any isolate that appear less than 30, you should neglect it. You should not provide it at the final antibiogram. Okay, the second include only the first isolate per patient per year, and also this is one of the most common question that is usually come to me regarding what is the meaning for first isolate per patient per year. So I will discuss it in the next slide, inshallah. And also they provide this recommendation to avoid the duplicate buys. Also, this is updated at least annually, and this is one of the recommendations for the CLSI. Again, they report only the person's susceptibility, and they does not report the MIC or minimum battery concentration. Also, they recommended they will stratify by the location, like the ICU versus non-ICU or inpatient versus the outpatient. This recommendation from the CLSI often causes confusion. So first isolate per patient per year. So I will discuss it and make it more clear for you now. This principle is that for each patient and for each organism, we only include the first culture results per year in the antibiogram. This means that if the same patient grow E. coli multiple times in the same year, so we only count the first isolate. Even if the later cultures show the organism that is more resistant, you still exclude those resistant organisms, because if we include them, this will cause a duplicate bias and will increase and overlay the resistance. So patient with chronic infection or long ICU stay should unfairly bias the data toward the resistance. So in order to make it more clear, I give you an example. Again, I will discuss this example. Patient A who is in the ICU and grow for the Pseudomonas aeruginosa 5 times in 1 year. The first isolate was susceptible to the meropenem, as you see, and the later isolate are resistant to the meropenem. So if you include all the five, it will increase the resistance. Well, the resistance will be much higher because this one of the patient is counted for multiple times. So the CLSI says that count only the first isolate that is susceptible. So in our case, we only will count the Pseudomonas that is susceptible to the meropenem. The results with antibiogram will reflect only the spread of the susceptibility across the population and not evaluate the resistance that occur in every patient. Why this matter? Because the antibiogram is a population tool and it is not used to reflect the chronic cases and does not reflect the bias toward the high resistant rates. And it should give the clinician the more realistic picture and what to expect when treating new patient empirically. So now we know what is the antibiogram, and the next question, why do we use it? Why we need to use the antibiogram? Simply to guide us for the most appropriate empirical therapy, also to develop hospital policy support protocols for different infection like community-acquired pneumonia, hospital-acquired pneumonia, urinary tract infection, and also it can help us in the surgical prophylaxis. And again, this is one of the series or one of the lectures that will be on the paid mode. I will discuss the surgical site infection and the wound infections and how those antibiogram can reflect or can uh, uh, change the recommendation regarding surgical prophylaxis. Also monitoring the resistant trend, detect the resistance pattern like ESBL or MRSA, support the antimicrobial stewardship program, like it will help us to update the restricted list, also in IV to oral switch and formulary decision. How to interpret it? Simply, you will match the syndrome likely pathogen. So you are knowing that the CAP or community-acquired pneumonia usually caused by the streptococcal pneumonia or Haemophilus influenza. So you will go to the antibiogram and you will go to the susceptibility pattern for both the streptococcal pneumonia and the Haemophilus influenza, and you can detect the most reliable empirical antibiotics that is susceptible to the streptococcal pneumonia and the Haemophilus influenza. Again, for the UTI, it's mainly caused by the E. coli and the Klebsiella. So you will go to the antibiogram and you will search for the E. coli and the Klebsiella and also see which of the antibiotic tested are most likely to be sensitive to those bacteria, also for HAP and VAB, so on. And for each bacteria, for each syndrome, you will see the most likely pathogens regarding the international guidelines. Okay. But as you see, this is for the CAP and urinary tract infection. Usually we make the matched syndrome with the likely pathogen for the community-acquired infection, not for the nosocomial infection. We usually, for the nosocomial infection, we see the most prevalent microorganism that appear in your hospital, and we rely on this bacteria, and we will discuss how this bacteria appear and the percentage for appearance or the prevalence of these bacteria, and also which antibiotics are being susceptible to it. But for the community-acquired infection, as I will discuss in the upcoming slides, for community-acquired infection, we usually match the syndrome with the likely pathogen. And then we check the susceptibility. We usually choose the antimicrobial that is more than 90%. Those are reliable choices. From 70 to 89%, we usually use them with caution, and maybe we can use them in combination in order to improve the susceptibility. And we usually avoid those antimicrobial that is less than 70%. Ignore any irrelevant organism unless there is a risk factors. Okay, and I will discuss it with you this on the upcoming lecture, inshallah. Always use the de-escalation when culture results are available, because as we know that the antibiogram, it's a population tool. It measures the most common microorganism and the most common susceptibility pattern for different antibiotics to those microorganisms on the population based. So if the culture appears for the patients, it's most appropriate to rely on this culture and to de-escalate based on this culture. For community-acquired infection, you should know that the pathogen predictable according to the guidelines. They usually illustrate the most common pathogen, and we go to the antibiogram and see those the susceptibility for different microorganisms, for different antibiotic to those microorganisms. Example, if you have CAP, you look streptococcal pneumonia, not Pseudomonas, and for community-acquired urinary tract infection, you look for the E. coli and Klebsiella. Hospital antibiogram may overestimate resistance so it's recommended, if it is possible, to do a separate antibiogram for the community-acquired infection, like outpatient or ER specific antibiogram. It will be much more better. But if it is not available, or if it is more tedious work to collect or to make a antibiogram specific for the outpatient, you can rely for the hospital antibiogram, but take care to not to look at the most common microorganism. You should look for the it's much more better to be pathogen specific, as I mentioned in the above examples. Use the antibiogram to confirm whether the first line empirical therapy is still appropriate. So you will not even choose the most common antibiotics based on the international guidelines. You will be more focused on the antibiogram and the choices for the antibiogram. For hospital-acquired infection, usually the pathogens are variable and often resistant, so you will not rely on the international guidelines for the pathogens. For the most common pathogens, you usually rely on the localized data based on the prevalence of your microorganism or the microorganism based on the hospital. Must review full ICU and hospital antibiogram, because the common pathogens are Pseudomonas, Acinetobacter, ESBL, Enterobacteriaceae, MRSA, VRE, and even the carbapenem resistance. So the empirical therapy guided by local pathogen distribution. You should know the most common pathogen, okay, not only rely on the on the international guidelines. Look also on the patient risk factor and severity, whether septic or not septic patient. Okay. So I will give you an example. For example, if you have an antibiogram for the sputum, okay, specimens, or the sputum antibiogram, maybe you will see that the most common pathogen is the Klebsiella or Acinetobacter, but according to the IDC guidelines, they usually illustrate that the Pseudomonas is the most common pathogen. So it's different. Maybe it's the most common microorganism may be different from international guidelines versus the local data. So septic versus non-septic patients, the recommendation will be different. Even if you have a single antibiogram, you will respond differently according if the patient is septic or not septic. For the septic patient, you need to give a broad empiric therapy, cover the most common bacteria, okay, guided by the ICU or local antibiogram, and you will make a rapid de-escalation once the culture return. But for the non-septic patient or more stable patient, you should go for the most common pathogen, the narrow empiric therapy, okay, and based on the antibiogram. Example, for the stable UTI, you can give nitrofurantoin if the E. coli is susceptible more than 90%. Guidelines versus local reality. The guidelines like IDCA usually provide a general global view, but the local antibiogram overrides the guidelines. Example, the guideline says Pseudomonas common in HAP. Your antibiogram says that the Klebsiella dominates and the Pseudomonas rare. So your empirical therapy will target Klebsiella, not Pseudomonas, unless there is a risk factor for Pseudomonas. And this is very important to know and to address this issue. There is a lot of limitations for the antibiogram because it's an aggregate data. It's not a patient specific. Also, it's provide an annual updates, okay, and it does not capture the rapid changes. Maybe there is an outbreak or something like that. It will not be able to capture these rapid changes. They does not involve the MIC value, just percentage susceptible. Also, they include pathogen that irrelevant for the community acquired infection. So in order to overcome this, you have two choices. Either you can perform antibiogram for the outpatient or for the emergency, or you can rely on the hospital antibiogram, but you should match the community acquired infection according to the most prevalent microorganism that appears or that is documented at the guidelines. Small isolate number, usually unreliable percentage. The take-home message: antibiogram is a cornerstone for the empirical therapy decision. You can respond differently in community-acquired infection. Use narrow predictable pathogen. For hospital-acquired infection, usually use broad resistant pathogen. For sepsis, you will provide an early broad spectrum and then de-escalate based on the culture. For non-sepsis, usually narrow the empirical therapy. Usually, the local data always override guidelines in case of hospital-acquired infection, not community-acquired infection. Usually combine your clinical judgment with patient risk factor with the antibiogram data. Don't rely only on the antibiogram and forget to monitor your patient risk factor or the clinical judgment. Before we finish, I would like to remind you that this conversation does not have ended here. I provide the professional courses in infectious disease, either in fully English or hybrid Arabic and English format to support ongoing learning. I also offer an online consultation to implement the effective antimicrobial stewardship program. I would like to connect, collaborate, and discuss your hospital-specific challenges. Please reach us on the WhatsApp. This is the number, and I look forward to working together to strengthen stewardship and improve patient outcome. Thank you. See you, inshallah, in the next lecture. Thank you so much for your participation, and goodbye.